Good evening, everybody, and I welcome you all to the DNB Clinical Meeting Series. Today, we have the anesthetic management of myasthenia gravis, which is being presented by Dr. Apoorva Kishore Prasad, who is one of our secondary residents, and is been ably assisted by Dr. Varsha. And we have none other than a neuroanesthesiologist from KIMS Super Speciality Hospital, Bangalore, Dr. Vivek Rayadurg, who's been with us a couple of times and has taken many lectures for our webinars as well. Dr. Vivek has been a topper at NIMHANS, Bangalore, and he's also the founder member of our Association of TIVA TCI. He has held many lectures, demonstrations, and workshops at many CMEs and conference, and with multiple publications, national and international, to his credit. His point of interest, of course, is IONM, TCI, anesthesia for patients at extremes of age, neurocritical monitoring, point of care monitoring. I welcome Dr. Vivek for this webinar, and the floor is all yours. Thank you.
Thank you, ma'am. Thank you for that introduction. So, good evening, all. Today we have Apoorva presenting a case of a patient coming for some surgery with a history of myasthenia gravis. Now, myasthenia gravis not very common in our setup, but not uncommon also. Most of us at some point or the other will encounter a patient suffering from myasthenia gravis. And because of its pathophysiology itself, it will present a serious challenge to our anesthetic management. So, hopefully in the next few minutes, we'll be able to discuss and probably improve our knowledge and which will help in our management in due course. So, Dr. Apoorva, if you are ready, you can proceed with your presentation.
Yes, sir. Thank you, sir. Good evening to one and everyone present here. Now, with the permission of Dr. Vivek, sir, I would like to proceed with our today's topic, anesthetic management of a patient presenting with myasthenia gravis. So, today's discussion will include a basic understanding of the disease process, the pathophysiology of the disease, how do a general or concise understanding of the clinical management of the disease, and how do we proceed for a patient for any surgical procedure coming to us, and how do we administer anesthesia to the patient. So moving ahead, we had a 38-year-old female, a known case of myasthenia gravis diagnosed 4 years ago, following complaints of fluctuating ptosis and easy fatigability. She was maintained well on tablet pyridostigmine 20 mg once daily with good symptomatic control and no history of myasthenic crisis or bulbar involvement. So taking into account this patient was vitally stable, had unremarkable general and systemic examination, and she was posted for elective laparoscopic cholecystectomy. Hematological, biochemical investigations were all within normal limits, along with her ECG and 2D echocardiography. The HRCT of thorax showed no evidence of hymoma or mediastinal pathology. With this basic understanding, we'll now proceed to understand about myasthenia gravis. So myasthenia gravis is an immunologic autoimmune disorder with antibodies directed at the acetylcholine receptors in the postsynaptic membrane of the neuromuscular junction. It is a chronic autoimmune disorder, and it is one of the most common neuromuscular junction disorder. The incidence is close to 1 case per 20 to 30,000 with a bimodal distribution with female predominance in the early onset. So looking in front of your slide, proceeding ahead, we'll try to understand the pathophysiology of the neuromuscular myasthenia gravis. So in front of you is a diagram of the neuromuscular junction, which is comparing the two situations in a normal neuromuscular junction and myasthenia gravis patient. So in normal, we can see that from the presynaptic nerve terminal, the synaptic vesicles come to the presynaptic membrane, and there they release the acetylcholine into the synaptic cleft. After being released into the synaptic cleft, due to normal number of acetylcholine receptors, it allows an effective neuromuscular transmission and muscle contraction. While in myasthenia gravis, we can see that the presynaptic nerve terminals, once they release the acetylcholine, due to either antibodies which bind to and block acetylcholine receptors, or due to complement activated destruction of the postsynaptic acetylcholine receptors, there is an inadequate number of acetylcholine receptors for the acetylcholine to go and act. So there is flattened junctional folds, and this leads to failed transmission, leading to muscle weakness. With this basic understanding, we'll move on to the types of myasthenia gravis, which can be broadly classified into an ocular myasthenia gravis, an early onset myasthenia gravis with an age of onset less than 50 years, with commonly associated with thymic hyperplasia. Then there is late onset myasthenia gravis, which has an age of onset more than 50 years with a normal and atrophic thymus, along with a male preponderance, while the early onset one has a female preponderance. Then there are thymoma associated myasthenia gravis, which can have age of onset is close to 40 to 60 years with thymic neoplasia, and can also have autoantibodies against acetylcholine receptors, titin receptors, and ryanodine receptors. And in some cases, there can also be some acetylcholine receptors against the voltage-gated subfamily of potassium. Then another, we have muscle-specific kinase antibody-associated myasthenia gravis, and in the very end, we have seronegative myasthenia gravis, in which we have no detectable antibodies against either acetylcholine receptors or muscle-specific kinase. Then, moving on from this understanding, we'll go on to have an idea of how do we classify myasthenia gravis. There are a few classifications. Among this, most commonly we use the clinical classification, also known as the Osserman's classification. So the Osserman classification actually divides myasthenia gravis into 4 classes, where class 1 being purely ocular myasthenia gravis, class 2 being a generalized myasthenia gravis, further subdivided into class 2A and 2B, with 2A having mild muscular weakness without any incapacitation, while class 2B also had mild to moderate generalized myasthenia gravis with slight muscle incapacitation, but no bulbar involvement whatsoever. From class 3 onwards, we have mild non-incapacitating muscular weakness, which involves oropharyngeal and respiratory muscles as well, while class 4 has incapacitating weakness of any muscle group, including the oropharyngeal and respiratory muscles. So moving on, the Myasthenia Gravis Foundation of America has added further one class into this clinical classification, which is class 5, mentioned in front of your slide, is a life-threatening respiratory insufficiency, which requires mandatory mechanical ventilatory assistance. So how will we have a patient presenting to us with myasthenia gravis? So the classical understanding, so the classical presentation, the cardinal feature is fluctuating muscle weakness, which presents as fatigue, and that fatigue presents as worsening fall in the contractile power rather than tiredness. So we generally, when we say fatigability, it is a sequential decrease in the contractile strength of the muscles rather than feeling any tiredness in the muscles. So muscle strength, and which may be normal at rest, and it is generally precipitated by exertion. So symptoms worsen later in the day. So there's a diurnal variation, and typically presents with the fatigability of voluntary muscles. Commonly involved muscles are the eyelids and the extraocular muscles. So in the eyelid muscles which present mostly with ptosis, and the extraocular muscle involvements which present as binocular diplopia. Proceeding ahead, in patients that proceed on from this ocular to the generally patients who remain in the ocular phase for 2 or more years have rare chances of progressing into the generalized myasthenia gravis. But patients in this phase, if the disease progresses, then it can involve the facial and the bulbar muscles, which will lead to laryngeal and pharyngeal involvement, and can have, which is very important from our anesthesia point of view, because that can lead to an increased risk of aspirations and can also implement our ventilatory parameters. So proceeding, it can also involve in certain cases, myasthenia gravis can be precipitated by certain factors, infection being the most common, pulmonary and viral infections, pregnancy, surgery, which is very important for us because any patient coming for a surgical procedure is inadvertently already being subjected to a precipitating factor. Electrolyte imbalance, most commonly hypokalemia, can cause muscle weakness in these patients. Any emotional stresses and drugs, especially antibiotics. So in the adjacent diagram, you can see we have a very short mnemonic to remember few basic drugs that cause or precipitate exacerbated myasthenia, which can be remembered as A, B, C, D, E. A being aminoglycosides, azithromycin, quinolones, ciprofloxacins. B being beta blockers and botulinum. C being chloropinone and calcium channel blockers. With D, we can have D-tubocurare, vecuronium, and magnesium. So how do we diagnose a case of myasthenia gravis? So the diagnostic evaluation basically begins with a clinical suspicion of myasthenia gravis. We can ask the patient for a sustained upward gaze, which the patient will not be able to sustain for longer duration. We can ask for a hand abduction to the holding outstretched hand in an abducted position, which again will lead to sequential as the muscles fatigue, the patient will have an inability to consistently keep doing that. Beyond that, if clinical suspicion uh, says and we want to confirm, we can go for few tests in a sequential manner, which are presented here. One of them being anti-acetylcholine receptor antibodies. These detects antibodies against acetylcholine receptors by radioimmunoassay. They generally take, the only drawback is they generally take about 4 to 6 weeks and are positive in about 50% of patients with ocular myasthenia gravis and close to 80 to 85% of patients in generalized myasthenia gravis. A positive test supports or is considered definitive for diagnosis of myasthenia. In case we are still not sure, and then what we can do is we can proceed for electromyographic test. So electromyographic test can again be done in two ways. In the first way, we can do one with repetitive stimulation. In repetitive stimulation, we provide a low frequency 2 to 3 hertz of repetitive stimulation to the motor end neuron plate, which over time produce a decremental response in the amplitude of the response. Will have a reduced response amplitude of the muscle. So a decremental response of more than 10% is again considered diagnostic for myasthenia gravis. In case we don't have this, we can now go to a single fiber electromyography, which tests in such a way. It is one of the most sensitive electrodiagnostic tests. It measures the jitter. A jitter is the gap between the two action potentials of different muscles, one in the limb and generally one of the facial muscles or ocular muscles, which are supplied by the same axons, and we understand the difference in the action potentials of both the muscles. So if we get a jitter or if we get a blocking, which indicates an impaired transmission at the neuromuscular junction. Apart from this, we have acetylcholinesterase inhibitor test, also known as edrophonium test or tensilon test. In this, we give a short acting and a rapid onset edrophonium in the dose of 2 milligrams, which produces an immediate which the onset starts in about 30 to 45 seconds and produces an immediate relief in the ptosis and is sustained for about 2 to 3 minutes. We can repeat this test by incremental dosing in case we do not get it in first till up a maximum dose of 10 milligrams. So nowadays, this is used less commonly because of the safety profile pattern. Which is why now we can do it in incremental doses so that it does not precipitate the cholinergic crisis. Then we can do the ice pack test, in which we keep an ice pack which is covered in either a surgical gloves or in any cloth, and we keep it over the eyelids. It follows the concept that lower temperatures improve neuromuscular transmission. So over a course of time, there can be improvement in the ptosis. All of these can be supplemented with imaging techniques which can provide us via chest X-ray, CT scan, or MRI of the thorax, which can provide us which can help us identify whether there is any thymoma or neoplasia related to it present there. So coming on to it, we'll have a short discussion on myasthenic crisis versus cholinergic crisis, which will help us proceeding ahead into our discussion into perioperative management of the patient coming with myasthenia. So both are medical emergencies with respiratory compromise, but have different causes, features, and management. So basic definition, myasthenia weakness is can be severe enough to require ventilation. Myasthenic crisis happens when the neuromuscular transmission has been depleted at such a level that patient is unable to sustain any voluntary skeletal muscle tone. While severe cholinergic crisis is due to excessive anticholinesterase medication leading to a life-threatening condition. So again, the causes could be the same exacerbating factor like pregnancy, infection, surgery, stress, non-compliance to drugs. While here, as we saw, is an accidental overdose or increased drug giving. Similarly, so cholinergic, so here we'll have same worsening muscle weakness, bulbar weakness, dysphagia, dysarthria, respiratory muscle weakness, probably progressing to respiratory failure. But in cholinergic crisis, we can have a very specific, classical dumbbells sign, which we also study during organophosphate poisoning, which here is also termed as short as SLUT syndrome, where you have salivation, lacrimation, urinary incontinence, diarrhea, or in short, GI upset, hypermotility, emesis, everything. So in diagnosis, basically both of these are clinical diagnosis based on clinical suspicion, but in cholinergic crisis, it also helps us I'm trying to give this in advance is that it helps us into post-operative or post-anesthesia care, where we diagnose it at times where in patients who have failure of coming out of requirement of mechanical ventilation post 24 hours. So both are medical emergencies. We need to maintain airway, administer high flow oxygen, and monitor the pulse saturation of the patients. In patients without gag reflex, probably place an oral airway. Once the airway and breathing has been stabilized, we identify and remove the precipitating cause. In treatment wise, for newly diagnosed for myasthenic crisis, we can either go with pyridostigmine, or in severe myasthenia or crisis, we can go with plasmapheresis with urgent neurological consultation, which can be life-saving. While here, we first have to stop all anticholinesterase drugs immediately and give atropine 1 milligram mg IV every 30 minutes till a maximum of 8 milligrams. Glycopyrrolate can also be used, and we can also repeat the atrophonium test every 2 hours to check if we are getting enough, if the response has been adequate to the treatment. So coming from myasthenia gravis to a further one of the another syndromes which can present with very similar complications for the anesthesia side is the Lambert-Eaton syndrome. So basically, how do we understand Lambert-Eaton syndrome and myasthenia gravis in concert? Because both of them have slightly reduced or resistant response to succinylcholine, have an increased sensitivity leading to a prolonged blockade for neuromuscular non-depolarizing muscle relaxants. So Lambert-Eaton syndrome is a presynaptic disorder, while myasthenia gravis is a postsynaptic situation. In Lambert-Eaton syndrome, the antibodies are against voltage-gated calcium channels, while here they are targeted at postsynaptic acetylcholine receptors. While in Lambert, the muscle weakness pattern is more towards proximal, predominantly towards the lower limbs. But here we'll have a fluctuating weakness, in which the limb involvement is definitely the last to happen and is very rare. In myasthenia gravis, effect of exercise improves the muscle response and the muscle strength, unlike myasthenia gravis, where repeated exertion leads to fatigue in the muscles. And another important thing is that Lambert-Eaton syndrome are more commonly associated with small cell carcinoma of lung, while myasthenia gravis, we have thymomas association more commonly. And anticholinesterase response will be good in the myasthenia side, while it will be weaker will have a poor response or minimal response on the Lambert-Eaton syndrome side. So moving on, we'll look at the management of myasthenia gravis. So management of myasthenia gravis is basically divided into 4 phases, into 4 broad categories. One is to enhance the neuromuscular transmission, which is achieved by anticholinesterase medications. Another is via immunosuppression to suppress the autoimmune destruction of acetylcholine receptors. And the other last, or the IV immunoglobulin in the same thing. And then there is plasmapheresis, where we have removal of circulating antibodies. And the last is the surgical management for thymoma and by thymectomy. So anticholinesterase and immunosuppressive. So anticholinesterase drugs are generally considered as the first line treatment. They help by increasing the acetylcholine at the neuromuscular junction, and also improve by increasing the number of the acetylcholine available to bind at the postsynaptic neuromuscular junction, and improves the muscle strength. The excess dosing has the only drawback to this is that excess dosing can lead to cholinergic crisis, and it can also antagonize the non-depolarizing muscle relaxants. Any anticholinesterase agents like pyridostigmine or neostigmine, these mostly provide symptomatic relief in myasthenia. Moving on, immunosuppressive therapy, in that we can go either with steroid, which will reduce the peripheral reactivity of the lymphocytes towards the acetylcholine receptors and acetylcholine receptors. Then azathioprine and cyclosporine, both these drugs are immunosuppressive or immunotherapy agents which need longer duration to achieve the minimal effect. Cyclosporine is slightly faster. These reduce the autoimmune destruction of acetylcholine receptors. So the goal is to improve muscle strength, prevent relapses, and achieve a long-term disease control. So moving on, the advanced therapies in myasthenia gravis are plasmapheresis, which is basically a plasma exchange to remove the circulating autoantibodies. These are very helpful. These are rapid onset and short duration effect, very helpful in patients with severe myasthenia or myasthenic crisis. But the Response, although being dramatic, is temporary and short-lived, and patients generally need about 5 to 6 exchanges over the course of 2 weeks. IV immunoglobulin, they modulate the immune response and reduce the autoantibody activity, but they require a large dose, nearly 2 gram per kg over next 2 to 5 days. They can be an alternative to plasmapheresis, and they can be provide a good short-term improvement. And the last thing is thymectomy, which is surgical removal. They are indicated they are indicated in patients with thymoma-associated myasthenia gravis, and it has also been found that they have excellent response in patients with generalized myasthenia gravis not associated with thymoma. Nearly 50% of patients with non-thymoma myasthenia gravis go into remissions, and nearly 90% patients definitely show an improvement in the clinical symptomatology. So now coming to the main discussion of our topic, that is how do we manage the perioperative management considerations in myasthenia gravis. So when a patient visiting to us for myasthenia gravis, we have to emphasize on the history taking, where we have to try to isolate the muscles involved, whether the patient has any oropharyngeal involvement, or just ocular involvement, is there any bulbar involvement, what is the duration and severity of the disease, the total dose of the anticholinesterase that the patient is on, and to assess the involvement of the respiratory muscles as well. Then in lab investigation, we should prefer to order for complete blood count, because in patients who are on immunosuppressive therapy, there can be reduction in their WBC counts. Then we need to have thyroid function tests, because many myasthenia patients are inadvertently associated with a lot of autoimmune thyroid dysfunctions. Along with that, we will need to have serum electrolytes. As I mentioned, hypokalemia can lead to muscle weakness and prolonged delay in our recovery from anesthesia. Blood glucose levels, because in patients with long-term steroid therapy, the sugar levels need to be monitored and controlled. LFT, liver function test and renal function tests are more important when we consider the immunotherapy drugs like azathioprine, which has a bad effect on the liver profile, and cyclosporine, which can have an acute nephrotoxic effect. Following this, ECG should be done to assess for any pyridostigmine associated bradycardia, chest X-ray to isolate any underlying pulmonary pathology, and perioperative ABGs and pulmonary function tests are a slightly controversial aspect of this, because it depends on the physician's personal choice, because they can be used as a baseline before proceeding into the disease and to help for extubation. So serial forced vital capacity measurements are used for the respiratory reserve, in which we look after the flow volume loops, which are more helpful when we have any mediastinal mass like thymoma, to understand the compare between the nature of the obstruction, whether it is fixed or is it dynamic. So moving on. So as I mentioned, so careful drug selection, vigilant monitoring is very important, and we have to ensure that our patients are in the remission phase. We have to ensure an adequate control of the disease and preferably go for an elective procedure. So moving on from here, ideally, we would want in the perioperative phase as well that our patients have been admitted while in remission at least 24 hours before the surgery, with preoperative physiotherapy and incentive spirometry as per patient's effort. Anticholinesterase therapy we would like to continue till the morning of the day of surgery. If we are on immunotherapy drugs, the guidelines suggest to omit them, preferably at least 2 weeks in advance. And if not, then we can also try to omit them on the day of the surgery, because there is a risk of causing an additive immunosuppressant effect under the influence of anesthesia. Steroid dose should also be continued on the morning of surgery. Proceeding ahead, before proceeding ahead, we would like to use an anti-aspiration. We would like to go ahead with an anti-aspiration prophylaxis, use an anti-sialogogues like glycopyrrolate or atropine. And in pre-medication, we should be careful while adding any opioids and benzodiazepines, depending on so that the patient doesn't get affected with the chances of respiratory depressions are reduced. So for induction of anesthesia, since our patients are highly susceptible, or they are highly susceptible to skeletal muscle weakness, we would prefer that our patients are intubated. Patients are induced with general anesthesia with spontaneous ventilation without the use of any muscle relaxants, because succinylcholine, since can have a variable response in patients with myasthenia gravis, because in case of succinylcholine, if the patient is not on anticholinesterase therapy, then the dose requirement of succinylcholine will go up much higher. The effective dose 95 will come close to 2.6 times of what we do normally. And if the patient is on on an anticholinesterase therapy, then in that case we can have a prolonged effect of succinylcholine. Non-depolarizing muscle relaxant have the same, because of increased susceptibility to the skeletal muscle weakness, will again have a prolonged effect. So we would like to do our induction with either with propofol or etomidate in an hemodynamically unstable patient. Intubation can also be achieved with volatile anesthetics, which provide adequate depth of anesthesia along with certain muscle relaxants. Use of opioids and benzodiazepines can be the physician's personal jurisdiction, but has to be titrated in order to avoid any respiratory outfalls. So after having gone through these concepts, after having proceeded with anesthesia, what do we proceed for the maintenance of anesthesia? Maintenance of anesthesia can be done either with spontaneous ventilation, with inhalational anesthetic agents. If in case we want to give a muscle relaxant where we need to have the ventilation in our control, we need to use short and intermediate acting relaxants which are less dependent on any organ based. It could be cis-tetracurium or tetracurium, which have Hoffman elimination. But recently, with the advent of recently Sugamadex, the better choice of muscle relaxant would be rocuronium with a combination of Sugamadex, because we can have assured and complete reversal. No residual paralysis can be there, and TOF monitoring has to be mandatory done. Apart from the standard ASA monitoring, which will be we have to monitor the TOF ratio and count. Another thing, while this we can add into this, is the use of epidural with GA in certain select cases, which will provide better analgesia, can also provide opioid sparing of systemic opioids and reduction in the required doses, and improve post-operative outcome. So individualized care and using the least drugs needed and monitoring closely. So recovery. Now, recovery is the area as an anesthetist where we are most worried and most focused upon, because we want to have a patient come out of anesthesia, preferably be extubated on the table. So during the recovery of anesthesia phase, in recovery we have to in extubation we have to extubate only in awake planes, and only go for extubation if a patient has been complete neuromuscular. If we have given a neuromuscular blockade, so a patient has complete neuromuscular reversal. So with the advent of rocuronium with Sugamadex, we can achieve it through that, because Sugamadex in the dose of 2 to 4 mg per kg, depending on the depth of the muscle relaxant that we have used, can completely reverse any aminosteroid-based muscle relaxant in about 4 to 5 minutes. But if we have used any non-aminosteroid like vecuronium or cis-tetracurium, we can use neostigmine in patients who have had good preoperative control of their symptoms and adequate dosing of anticholinesterase therapy is going on. So preferably better to avoid. Also, one thing which we would like to ensure is in preoperative phase as well is to put in a nasogastric tube in patients, so that we have, in case we want, if there is any cholinergic crisis happening, we can have a patent. And if also we don't know whether how sure are we about restarting our patient orally, we can have a nasogastric tube to start our patient on pyridostigmine therapy. So extubate only after adequate recovery with hemodynamic stability, if the patient can maintain adequate oxygenation and ventilation, have the protective reflexes, which we can check with adequate good cuff reflex, a good head lift of more than 5 seconds, has a good hand grip, a TOF ratio of 0.9 or more, a TOF count of 4. And if we have these clinical signs along and these TOF count, then we can proceed ahead with our extubation. So similarly, in this perioperative cholinesterase management, in case we land up with this situation when we have started and adequately managed our patient, so we have to understand we have to maintain oral cholinesterase therapy up to the point of surgery. Reversal of neuromuscular blockade is possible with neostigmine if indicated by nerve stimulator. If our TOF monitor is not showing any count, if the count is 0 or less than 0.5, then neostigmine will not be able to adequately reverse. If there is no twitch, then it will not be able to adequately reverse the neuromuscular blockade, which is why we can see that why TOF count is so much important. Also, an IV neostigmine. So again, in management of anticholinergic therapy, we can start with an IV dose of, in case we encounter with a cholinergic crisis, we can start with 2.5 to 5 milligram bolus, increasing with 1 milligram every 2 to 3 minutes with a maximum equivalent dose to oral pyridostigmine. For an average, an IV neostigmine is nearly generally is equivalent to 1/30 ratio of the oral, is equal to the 1 milligram of neostigmine is close to equal to the 30 milligrams of pyridostigmine. So continuous cholinesterase therapy, appropriate reversal and monitoring ensures safe perioperative outcome. So in post-operative period, once we have ensured that my patient has been adequately, has come out of his muscle relaxation adequately, then most of this patient, and I have ensured that my vocal cord abduction are normal, I don't have any stridor or no sign of any impending respiratory failures, there is no inability to cough, no reduced vital capacity, there is a sustained hand grip, and I have proceeded, then we can go ahead with the extubation. But looking at the condition of this patient and the requirement of management, inadvertently, these patients will require either a high dependency unit or an intensive care unit monitoring, especially so if the patient is coming with a severe disease. So close monitoring of the respiratory status, early detection of the respiratory fatigue, and timely ventilatory support if required. Now, how do we assess whether my patient needs post-operative mechanical ventilation or whether we can go ahead with extubation on table? So that help for early recognition and management is achieved via a scoring called as Leventhal scoring. So this is the criteria that helps us to assess that whether do I have a patient that is a high risk for the surgery, for the anesthesia, and might require prolonged post-operative mechanical ventilation. So what are the risk factors? A vital capacity of less than 2.9 liters, a disease duration of more than 6 years, pyridostigmine dose of more than 750 milligrams per day, any associated pulmonary pathology, a chronic pulmonary disease, patient has bulbar symptoms, previous history of myasthenia crisis, high acetylcholine receptor antibody levels more than 100 nanomole per liter, and there is marked decrement on the repetitive nerve stimulation test. If a patient has nasal speech, dysarthria, dysphagia, a weak cough, then presence of one or more risk factors increases the likelihood of post-operative respiratory failure and need for prolonged ventilation. So careful preoperative assessment and intraoperative management will help us to avoid this situation, and instead of rushing into a situation where we try to extubate a patient on table and land up in the soup, we can proceed to electively extubate the patient. So now coming back to our case history of this patient which came to us, and we managed accordingly. So we went ahead, since our patient was very well controlled, has a very controlled history, patient was vitally stable and had unremarkable general and systemic examination. So we decided to proceed ahead with trans-intravenous anesthesia technique by targeted controlled infusion, that is TIVA using TCI with an L-well pharmacokinetic model for 1% propofol and remifentanil infusion. So why did we prefer that? Because we wanted to avoid muscle relaxants. The propofol and remifentanil combination can provide adequate conditions of for airway manipulation, which we achieved by monitoring the patient with under BIS monitoring. So once we were able to achieve a BIS score of less than 60 on these two, then we proceed ahead with the securing of the airway. Avoiding of inhalational also gave us the added advantage of having any residual muscle fatigue or more effect on muscle relaxation effect. And also TIVA has a very good benefit of giving us more clear-headed recovery from anesthesia. So we proceeded ahead with a 1% propofol with L-well model with a targeted effect site concentration of about 1 to 2 micrograms per ml. And for remifentanil infusion, we targeted doses of about 5 micrograms per kg body weight with a targeted concentration at effect site close to 5 nanograms per ml. And in that, we proceeded ahead. So after having done this and having successfully conducted this case, we should also know that what are the recent advances that have come. So there is there are two drugs that have come. One is innovations which are improving the outcomes. One is rituximab. It is an anti-CD20 monoclonal antibody which reduces the pathogenic B cells and autoantibody levels and is very well used in effective in refractive myasthenia. Tacrolimus is a calcineurin inhibitor which suppresses T cell activation and can be used in generalized myasthenia gravis. The four like IV immunoglobulin, Sugama Dex, quantitative TOF monitoring, and plasmapheresis we have already discussed in our previous slides. So in summary, what we have understood through today's slides is that in the pre-op phase, we need to focus on disease optimization, continuation of medication, respiratory assessment. In the intra-op period, avoid and minimize muscle relaxant use. TOF monitoring all the way through. Volatile anesthetics can be good, and TY and careful opioid use with titration, and TY and TCI can be your best friends when handling such cases. And in the post-op period, ensure adequate reversal, avoid any adequate reversal, and preferably close monitoring in an ICU or HD unit. So careful planning, vigilant monitoring, and individualized management are key to safe outcomes in patients with myasthenia gravis. So the key VIVA protocols, pearls that will help us for in these situations are resistant to succinylcholine is one concept, sensitivity to the non-depolarizing muscle relaxants, continuation of pyridostigmine till surgery, the bulbar weakness, TOF monitoring, and extubation after complete reversal. So understanding the disease will help to plan the anesthesia, monitoring objectively, titrate carefully, and securing airway to ensure safe recovery. So to conclude, myasthenia gravis is a neuromuscular autoimmune disorder causing fatigability. Careful perioperative planning is essential. Judicious use of muscle relaxants, TOF monitoring is critical, and major goal is prevention of post-operative respiratory failure. So optimized preparation, appropriate anesthesia technique, and vigilant monitoring, close monitoring with TOF guided recovery will lead to a good result. So this is a multidisciplinary care involving teamwork, anticipation, and individualization to ensure a safe perioperative outcome. So anticipate, monitor, support, and ensure a good recovery. So with this, I would like to thank you. With knowledge, vigilance, and teamwork, we empower safe anesthesia care in myasthenia. So we understand the disease, plan carefully, monitor precisely, support recovery. Safe hands, steady mind, stronger outcomes. Together, we make every breath count. Thank you, sir. Thank you, ma'am.
Good, Apoorva, actually. Very crisp and clear presentation. Very well made slides also. And you can see that even though you have a ventilator standby, your patient is doing good on nasal prongs itself. So, well managed case also.
Thank you.
So, just a couple of questions. It is not just for Apoorva, it is for all the residents. Anyone can volunteer to answer. So, you spoke about hydrophonium test, isn't it?
Yes, sir.
We are rarely doing it nowadays. Why is that so? People have moved away from hydrophonium test. Why do you think that has happened?
So, because of the safety profile of the test, sir, so that if the patient has been not very well, is not in a very well controlled disease or a remission phase, the sequential dosing of hydrophonium can land up with cholinergic crisis.
Oh, it's a short-acting drug, no?
Yes, sir.
So
with a rapid onset.
It's a very good test, you know. If your patient goes into respiratory failure in the post-op period, it is one of the tests which will easily help you whether what to do next, whether the patient has gone into myasthenic crisis or cholinergic crisis. So the problem with hydrophonium was that it is a very potent anticholinergic by itself. So the anticholinergic adverse effects, bradycardia, and more importantly bronchospasm, that used to be pretty severe and pretty difficult to manage if they went into the crisis. That is why it went off practice. There are better tests now. Ice pack test is a good test. One of the recommendations is that you have an ice pack ready in the post-op period. So if your patient starts developing weakness, that is one of the tests you can do. If he improves with ice pack, then it is probably a myasthenic crisis, and to supplement IV neostimulant. That is what is. Okay. So next, okay. One more thing I wanted to ask is, you said you don't want to use much of opioids because there is already borderline respiration. You don't want respiratory depression. So what would be your plan for post-operative pain management in this patient? I know it is a laparoscopic surgery. There won't be much pain. Would you choose IV patient-controlled analgesia in this case?
So we can go with multimodal plan with non-steroidal anti-inflammatory drugs with paracetamol, IV paracetamol, and we can not in this case, but for certain we can also go with epidural-based analgesia plans for patients who have mid-thoracic surgeries,
Correct.
like that in those patients as well. And other than that, sir, we can go with yes, sir, or with a tap with transverse abdominis plane block as well. Sir. Tap block can be given in this case.
Yeah, correct. So if you get into a center where regional anesthesia is a major this thing, no,
Yes, sir.
they will go on to blocks, because anyway regional blocks are now becoming routine practice, especially in a case where you want to avoid opioids. So you did this case on remifentanil and
And propofol.
remifentanil is an extremely short acting opioid. Excellent choice for intra-op analgesia, because you will completely avoid relaxants. You can go as high as you want to give analgesia, as well as suppress intraoperative ventilation to control ventilation. But there is no post-operative analgesia with remifentanil. So you need to have a good plan before extubation.
Yes, sir.
So transverse abdominis is not such a great option. There are other blocks called rectus sheath block and external oblique intercostal plane block. Okay, for a case of lap cholecystectomy, the ports are in the around the umbilicus and the upper part of the abdomen. Okay, so the tab block covers only the infraumbilical part of the abdominal wall. So not such a great choice. But in other cases, if it is an appendix or any other case, that block. So always have a plan of regional. Epidural is a good choice, but maybe an overkill in the case of laparoscopic surgery.
Laparoscopic case.
But if it was a major surgery, you can probably go ahead with epidural. Otherwise, regional blocks, facial plane blocks, and NSAIDs and paracetamol give excellent coverage. You cannot completely avoid opioids in the perioperative. So, good. If suppose your case has gone well and they want to take you for further discussion, one of the things that will be asked is, what is the effect of pregnancy on myasthenia gravis? Suppose you have a patient of myasthenia gravis coming to you. The patient is a known case of myasthenia gravis. The patient has presented to the antenatal clinic. Her pregnancy is confirmed, and the obstetrician sends the patient to you in the first trimester itself. Okay, the obstetrician has said she doesn't have much idea. She wants you to counsel regarding the disease to the patient. The delivery part and the labor analgesia part are far apart. So you just have to explain to the patient what is going to happen to the disease during pregnancy. So what will you tell the patient?
So pregnancy is in itself a precipitating factor for myasthenia gravis.
Yes.
And the patient can have a worsening of the symptoms. But at any point, if it progresses to the bulbar symptoms or respiratory involvement, then it becomes a high risk case. So we have to counsel the patient, and make them understand that there can be post-operative ventilatory requirements. We might have to go ahead with general anesthesia if time does not pursue it, or if any obstetrical emergency arises in this situation. So counseling them for post-op prolonged ventilatory requirement would be one of the key concerns.
Correct. So the stress of pregnancy worsens. That is correct. So what has been seen is, in the first trimester, myasthenia generally worsens. The peridostigmine requirement goes up in the first trimester. But in the second and third trimester, because pregnancy by itself is an immunosuppressed state, the T cell, basically it is a T cell mediated disease, and in pregnancy T cell mediated immunity generally goes down, and there is a higher level of plasma corticosteroids because of excessive secretion during pregnancy. So during the second and third trimester, the disease actually improves. The symptoms get better. The pyridostigmine requirement comes down. So they'll have to be in regular touch with their primary physician who is taking care of the disease. Their dose needs to be titrated. And again, delivery and postpartum period is major stress, so she can worsen anytime. Just because the delivery went well or because the cesarean went well doesn't mean she is good. Second day, third day post-operative, they may end up in respiratory failure, so they need to be monitored pretty well closely. Cannot like how we discharge on the first or second day after delivery, we need to monitor them better after delivery. That is
Yes.
one thing. And if this is an intensive, it is a short case in the ICU. If it is an intensive care question, you discussed about Peter-Lambert syndrome, and you also discussed about cholinergic crisis. Any other differences which you can encounter in the ICU?
Guillain-Barré syndrome.
Correct. Good. Who was that? Can you elaborate on Guillain-Barré syndrome and how would you differentiate?
So it will have an ascending paralysis.
Right. Which one?
Guillain-Barré syndrome.
Yes, correct.
And then generally, sir, myasthenia will have a fatigability and there will be no muscle atrophy. While this primary myotonic pathologies like Guillain-Barré or other will also have muscle atrophy associated with them in
the
severe
long
cases,
term.
long term.
Correct. But when in the when presentation in the ICU, any other difference? Correct. Good. Any other differences? So, like she said, one is ascending paralysis in GBS. In myasthenia, it's
Asymmetrical
primarily
involvement.
ptosis and asymmetrical. Correct.
Ptosis.
Yeah. Then history. Myasthenia
Yes, sir.
usually has a long history. There is waxing and waning. They get better, again they worsen. GBS is more acute. They give a history of infection. Probably most commonly it is abdominal infection causing diarrhea, and then they develop ascending paralysis. Any other? No, not commonly seen, but you should know. Is botulism. Botulism also presents with asymmetrical weakness, including bulbar paralysis. But what is the main feature differentiating botulism and myasthenia? Botulism has more of autonomic symptoms, while myasthenia is primarily somatic. There is no rarely autonomic involvement in. There is a lot of arrhythmias. Cardiac function may have gone up and down, and then there is cholinergic thing also. There is loose stools. There is bradycardia. There is dryness. All that is seen in botulism, which is not seen in myasthenia. And someone also commented hypokalemic periodic paralysis, I think. So would you like to elaborate? So hypokalemic periodic paralysis, again, it's a what receptor is involved?
Potassium.
No, that's the homework. I'll not tell because I'm not sure myself. So it is again an asymmetric weakness, but it involves purely skeletal muscles. There is no bulbar involvement, and there is rapid correction if you correct the potassium levels. That is the main differentiating factor between you on your ABG or on your labs. You will see that the potassium levels are low, and then there is a correlation as any event which precipitated the low potassium levels, like an infection or like an insulin overdose to correct some other issue, or like an excess of diuretic dose which precipitated hypokalemia would have caused the weakness. So you will have that history, and then with the potassium correction, the weakness immediately improves. So that is a differential. Someone asked maximum exacerbation occurs when? So in pregnancy, there is worsening in the first trimester, then improvement in the second and third trimester, and again worsening in the peripartum period. It is related to stress. So maximum stress occurs during delivery and immediate postpartum. That is when the disease also worsens maximum. That is when maximum monitoring is needed. So, other question was, will pressure support help with spontaneous breathing? It will help. You will not need to intubate all the time. But the problem here is more of a bulbar weakness. There is inadequate respiratory effort being generated. So if the effort is generated, your pressure support will help to improve the airway pressure so that the breathing is better. It will help, but you will. The other thing is, because there is already a bulbar weakness, the gag is impaired, the swallowing is impaired. So you will also need to protect the airway. So intubation is not just to ventilate; it is also to protect the airway and to protect from pneumonia. So it will help for some time, but if the disease is worsening, you will have to ultimately secure the airway to prevent other complications. Anything else anyone wants to add? Kalpana ma'am, anything you want to add?
Just 2, 3 things. I think he should have mentioned about the prehabilitation before the patient has been taken up for surgery. So that's what all we do, like good incentive spirometer, steam inhalation, all these things. Albumin should be good, nutrition should be good. These are the simple things that you would generally look into. I think, Dr. Vivek, if you have no more questions, let us see how attentive our residents were. And can we have a short kind of a
Yes, ma'am.
if it's
Yes,
okay?
yes.
Yeah.
Kalpana, can I give you my experience?
Yes, madam. Madam, can you share
So
that after
after
the
the
quiz? After the
okay,
quiz, can we do that?
okay, sure.
Can you stop sharing the slides, Dr. Apoorva?
Yes, ma'am.
Okay, here we go. Can I have all the residents on screen, please? Can you all see my slides?
Yes, ma'am.
Can you all see my slides, everybody?
Yes, ma'am.
Yes, ma'am.
Great. So can we go by order, or somebody will raise their hands? How are we planning to do that? So myasthenia gravis patients are most sensitive to which of the following drug?
Curonium. Rocuronium.
Okay. Who's answered that? Apoorva. Is that Apoorva?
Yes, ma'am. I think someone else was also there. There are two voices.
Okay, fine. Response to succinylcholine in myasthenia gravis is what? Is it exaggerated and prolonged? Is it normal? Is it resistant and unpredictable, or it is completely absent?
Resistant.
Resistant
Resistant
and
and unpredictable.
Okay. Preferred reversal agent in myasthenia gravis is what?
D. Sugammadex.
Okay. And why you think Sugammadex is a preferred reversal agent?
Ma'am, because we have clear recovery. Chances of residual blockage residual neuromuscular blockage are very less.
And
And with
avoid all the
neostig,
cholinergic complications.
cholinergic crisis precipitation will also not happen.
Yeah. Which antibiotic would you avoid in a patient with myasthenia gravis?
Gem.
Correct. Who answered that?
Mm.
Who answered that?
Anushri was one.
Gentamicin.
Anushri, what is the reason?
Ma'am, it is nephrotoxic, so maybe.
No, because it impairs the neuromuscular transmission, no, and hence it will precipitate weakness. Correct? Which is the most important monitor in myasthenia gravis?
C.
Quantitative.
Quantitative talk.
Which are the predictors of postoperative ventilation, young age, bulbar weakness, ocular symptoms, or short surgery?
B, ma'am,
Yeah.
bulbar weakness.
Oh. Salivation, diarrhea, meiosis after excess of pyridostigmine suggests what? Is it a myasthenic
Cholinergic crisis.
C.
Good. The best anesthetic strategy in stable myasthenia gravis is large dose relaxant, deep benzodiazepine, avoid
C.
relaxants.
Avoid relaxants.
Avoid relaxation.
Very good. True statement regarding extubation for a patient with myasthenia gravis is tough monitoring is unnecessary, residual block is tolerated, extubation should be delayed until full recovery,
C.
and head lift has
Delay
Delay
extubation until full recovery.
Very good. The hallmark of myasthenic crisis is what? Excessive secretion, respiratory muscle weakness, meiosis, or is it fasciculation?
Excessive secretions.
Meiosis.
Sorry, ma'am. The respiratory muscle weakness. B.
Respiratory muscle.
Which is the most reliable indicator for neuromuscular recovery?
Top.
Hand grip,
Of more than 0.9.
commonest cause of perioperative deterioration is what? Hyperglycemia, infection, hypothermia, or hypertension?
Hypothermia.
Infection.
Yes.
Infection.
Infection. Yes, correct.
Hypothermia, better.
Common induction agent in
Transmission.
myasthenia gravis is
Propofol.
Propofol.
electrolyte abnormality worsening the weakness is what? Hyponatremia, hypercalcemia.
Hypermagnesemia.
Yeah, very good. Pyridostigmine is usually stopped preoperatively, continued, contraindicated, or replaced with
Continued.
residual blockade may lead to what? Malignant hypothermia, rapid awakening, respiratory failure, or hypertensive crisis.
Respiratory failure.
Yes.
Volatile agent commonly used safely is what? Ethers,
Sevoflurane.
Aminoglycerol worsens the myasthenia gravis because of
Impairing
Impairing neuromuscular transmission.
high risk factor for postoperative ventilation, young age, minor surgery, bulbar involvement.
Bulbar
or
involvement.
best relaxant strategy is what? Standard dose, double the dose, titrated with TOF, or continuous?
Titrated dose with TOF.
Which postoperative analgesic strategy is best in myasthenia gravis?
Opioid-free
Multimodal.
Okay. A patient with myasthenia gravis undergoing thymectomy should ideally have what? No monitoring, quantitative neuromuscular, only ECG, or only pulse oximetry?
Quantitative
Neuromuscular
monitoring.
Which statement about regional anesthesia in myasthenia gravis is true? It's absolutely contraindicated, often beneficial if respiratory function is preserved, always causes respiratory failure, cannot be combined with sedation.
B, ma'am. Beneficial if respiratory function is preserved.
Which symptoms favor cholinergic crisis over myasthenic crisis?
Which symptom?
Cholinergic crisis over myasthenic crisis. Dryness, tachycardia, and fasciculation.
Yes. Preferred ICU therapy for severe myasthenic crisis include what?
IVIG or plasmapheresis.
Okay. Great. I think Dr. Daigode, madam, you wanted to share something with us.
Yes, I had
case of myasthenia gravis in early 20s, and he was for thymectomy. And surgeon wanted to do it thoracoscopically. So he wanted me to put in a double lumen tube. So I didn't want to give relaxant. So can I ask these people, how did I induce? How could you induce in such a case with double lumen tube? Can anybody answer?
Ma'am, with propofol and volatile agents, ma'am, inhalational agents.
Yes. But with that, you can put a double lumen tube?
And with, ma'am, some topical anesthesia over the vocal cords, like 4% lignocaine spray or...
Will that be enough for double lumen tube?
Not be, yes, ma'am. For double lumen tube, the size is bigger.
So what I did, what you said is okay, up to endotracheal tube. I put in one size smaller endotracheal tube, and through that, I injected lignocaine spray and then gave a ventilation. So with that, the lignocaine got sprayed into the bronchi also. And then I could put the double lumen tube. Did you understand? With propofol and fentanyl and with local oral spray and cord spray, I put the endotracheal tube, and through the endotracheal tube, I injected 10 ml of lignocaine of 2% and then gave a ventilation. With that lignocaine got sprayed into the bronchi.
Into the bronchi, yes, ma'am, with the air blast, yes, ma'am.
And then I could put the double lumen
Put that
tube.
double lumen
And
tube.
I, of course, checked it with the fiber optic bronchoscope. So this was case for a thymectomy. It was done through the right thoracoscopic procedure. Just my experience. This was about, so I avoided relaxant altogether throughout the procedure. And the patient had myasthenia gravis for a year or two. And he was well maintained on pyridostigmine, 15 milligram, I think 3 to 4 times a day. So that way he was stable and all other parameters were good. So I could, conduct this case in this way. Okay.
Yes.
I hope you all followed.
Dr. Vivek, you have any more final comments?
It was a very good presentation. Actually, it was refreshing for me also. After a long time, I had to read about myasthenia. So good. Actually, I think it's a good initiative. Also, people coming together and discussing it for the benefit of all, not for the students or just for our benefit also. It's a very good initiative also.
Kalpana, one thing I want to say. Kalpana, can you hear me?
Yes, ma'am.
Yeah. Good evening. It was very good, Apoorva. It was very good, and your questions also was very good. Okay.
Thank you, ma'am.
Yeah. See, in this, I have done 4 or 5 myasthenia cases, and 3 of them were cesareans, and all of them were preoperatively maintained very well, and so nothing was expected, but all 3 neonates went into myasthenic crisis, in spite of mother being well. So this is what you should remember always. And first was on the table itself, so I was there around, and then it was in Nair Hospital, so there was not a system of calling pediatrician. Nowadays, the pediatrician is mandatory in the theatre. That time there was nothing, and while child was being taken to the nursery, child went into myasthenic crisis. So remember this, newborn can get into myasthenic crisis in spite of mother being well. Okay. So observe the newborn, and she always shift with the baby, with the mother, and not alone. somebody has to accompany this thing. Who can
Yes.
this crisis can be managed. Okay. And secondary, I thought the antibiotic cover is extremely important to be started pre-operatively. As Kalpana said, it has to be prepared properly. The antibiotic cover has to be, and hypothermia to be maintained very much. So otherwise, little hypothermia and that also induces the myasthenic crisis. So good, it was overall very good. For us also, it is brushing up. Thank you so much.
Excellent presentation and a good discussion. Vivek, I think, gave good comments also. And it was very good.
So just to add
Thank
to
you.
ma'am's, just one last word. Can the students tell us why, like ma'am said, why the infants, I mean the neonates go into a crisis? Can you tell us the reason? So the reason is all the antibodies, no, there is placental transfer. So the antibodies get transferred to the fetal circulation also. But the disease control is with pyridostigmine. Pyridostigmine is an ionic compound. There is no placental transfer. So even though the child, baby gets antibodies, pyridostigmine is not transferred. So it may not be the disease per se, it is just a transient transfer of antibodies which needs acute care, and then the child may not get the disease in the future. So
Yeah, child
like ma'am said, it's a very good point. If you're involved in peripartum care, along with the mother, the baby also needs intensive care in the initial few days. Thank you, ma'am, for that input.
Thank you.
Dr. Vivek,
Thank
what
you.
about trial of labor?
Ma'am, if the disease is well controlled, I think if there is no weakness, trial of labor can always be given. It should help, of course, with good analgesia, probably an epidural analgesia. But like we already discussed, labor and delivery are stress. So during the process of labor, the mother can end up in a crisis. So we should be ready to resuscitate as well as to immediately convert it into a cesarean section and deliver it fast with full preparation for GA, like how we would do for a case of myasthenia.
Okay.
Kalpana, thank you so much. You are getting good people for us, in the sense, because of Kalpana's exposure, it is possible she can get a good faculties for us. Thank you very much, Kalpana. And student, we are very lucky, huh?
Not only that, we and Dr. Vivek, and we also had a mock trial yesterday, and Dr. Vivek was kind enough to be in the mock trial.
Yeah,
It is the effort which is being put in. It is very good to see that people are still showing interest to teach, and on the part of the students to. I know they must be busy in their routine clinical work, so still to be able to prepare slides and then to practice and present. It's good on
I think the slides
while
were
presenting
fantastic.
the slides, he also had my photograph where he was darting me every day.
Slides were fantastic.
Okay. So thank you so much, Dr. Vivek. It's really a pleasure to have you. And I thank you everybody to be present today. And Apoorva, thanks once again. Varsha, thanks once again for being with us tonight. Thank you, everybody. Good night.
Good night.
Thank you, ma'am, for the opportunity. Thank you.
Thank you, ma'am.
Good night. Good night.
Bye.